of seropositive arthropathy. So we have four types of seropositive arthropathies right now. It's a rheumatoid arthritis, SLE, scleroderma, and dermatomyositis. Clinical features, history. In rheumatoid arthritis, there will be asymmetrical polyarthritis, small joint involvement, morning stiffness greater than 1 hour, dyspnea on exertion, interstitial lung disease in less than 30%. On physical examination, you will find early effuse joint, synovitis, subcutaneous nodules, or extra-articular manifestation, late joint deformities, bone-on-bone crepitus in advanced disease. Inspiratory crackles, lab non-specific, increase ESR in 50 to 60%, increase CRP, increase platelets, decrease hemoglobin, chronic disease, decrease WBC, neutropenia rare, specific RF positive in 80%. Anti-CCP positive in 80%. Radiograph very early normal, then early periarticular osteopenia, later joint space narrowing, erosion, systemic concentric, interstitial lung disease, and lung nodules. Okay. So SLE, history, multi-system disease, rash, mouth ulcers, photosensitivity, Raynaud's, alopecia, cardiac and pulmonary serositis, CNS symptoms, and glomerulonephritis. Physical examination, check blood pressure, rash, mouth ulcers, alopecia, Raynaud's phenomena, serositis. If used, typically small joints can be minimal. Look for soft tissue swelling. Lab findings will be increased ESR, decreased platelets, autoimmune, decreased hemoglobin, autoimmune, decreased WBC count, leukopenia, lymphopenia, increased creatinine, proteinuria, RBC cast. Specific NA positive in 98%, anti-DS DNA positive in 50 to 70%, anti-SM positive in 30%. Decreased complement C3 and C4 level, total hemolytic complement, false positive VDRL in SLE subtypes, and APLA. That is, I think, antiphospholipid antibody something. Okay, radiographs, non-erosive, osteopenia, soft tissue swelling. Okay, scleroderma, history, skin tightness, stiffness of finger, Raynaud's, heartburn, dysphagia, shortness of breath on exertion due to pulmonary hypertension or interstitial lung disease, renal crisis with new onset hypertension or hypertensive urgency and emergency. Physical examination, skin tightness on the dorsum of hand, facial skin tightening, telangiectasia, calcinosis, non-effused joint, inspiratory crackles, features of right side heart failure. Lab, non-specific, decreased hemoglobin, normal WBC, possibly increased creatinine, proteinuria. ANA positive in greater than 90%. Anti-topoisomerase 1 diffuse. Anti-centromere usually in crest, C sidebars, okay. Radiograph, pulmonary fibrosis, interstitial lung disease, esophageal dysmotility, calcinosis. Okay. So yeah, dermatomyositis, history, heliotrope rash, periorbital, Gottron's papules, violaceous papules over knuckles, and IPS, interphalangeals. Poikiloderma, shawl sign, photosensitivity, macular erythema over the chest and shoulder, proximal muscle weakness, more pain, dyspnea on exertion. Heliotrope rash, okay, physical examination, heliotrope rash, Gottron's papule, shawl sign, proximal muscle weakness, usually painless, inspiratory crackles. Lab findings will be increased CRP, decreased hemoglobin, normal WBC, increased CK. CK elevated in 80%, ANA positive in 33%, anti-Jo1, anti-MI2, muscle biopsy, EMG, and MRI. Radiograph, esophageal dysmotility, interstitial lung disease, and calcification. Okay, so we have rheumatoid arthritis, definition, chronic, symmetric, erosive synovitis of the peripheral joint, wrist, MCPs, and MTPs. Metacarpophalangeal joints and metatarsal phalangeals, characterized by the inflammatory joint disease and extra number of extra-articular features. One joint with a definite clinical synovitis swelling not explained by another disease. Okay, the sidebar, RA is an independent risk factor for atherosclerosis and CV disease. RA is associated with increased overall mortality, morbidity from all causes, CV disease, neoplasm, especially lymphoma and infection. Okay, then we have ACR or Euler classification criteria for rheumatoid arthritis. Criteria, joint involvement, swollen or tender, one large joint, shoulder, elbow, hip, knee, ankles, 2 to 10 large joints. It will be equals to 1. Then if 1 to 3 small joint, MCPs, PIPs, wrist, second and fifth MTPs, then it will be score 2. 4 to 10 small joints, score 3. Greater than 10 joints, at least one small joint greater than then the score will be 5. Okay, serology, negative RF and negative anti-CCP, 0 scores. Low positive rheumatoid factor or low positive anti-CCP, 2 score. High positive rheumatoid factor or high positive anti-CCP, 3. Then acute phase reactants, normal CRP, normal ESR, abnormal CRP and abnormal ESR. So if it's normal, then 0, and abnormal, then we can score it as 1. Duration of symptoms, less than 6 weeks, it will be 0. Greater than 6 weeks is 1. Okay, total score of greater than 6 definite rheumatoid arthritis must have greater than 1 joint with definite clinical swelling and not better explained by another disease. Okay, common presentation, morning stiffness greater than 1 hour, improve with use. Symmetric joint involvement initially involves small joints of hands and feet. Constitutional symptoms. Okay, here is the picture which is showing which joints are involved. So PIP, MCP, wrist, not first carpometacarpal, elbow, shoulder, knee, ankle, metatarsal, cervical spine. Okay, so pathophysiology, autoimmune disorder, unknown etiology, complex genetic and environmental interaction lead to disruption of immune tolerance, ultimately resulting in synovial inflammation. A genetic predisposition, HLA, DR4, DR1 association, 93% of people have either HLA type cytokine promoters, T cell signaling. Environmental predisposition, induction of enzymes that convert arginine to citrulline caused by environmental stress, cigarette smoking, propensity for immune reactivity to new epitopes created by protein citrullination. Inflammatory process causes transformation of synomium into invasive pannus tissue that degrades cartilage and bone with absence of repair. Elevated TNF level increases osteoclasts and decreases osteoblasts at the site of inflammation, results in periarticular osteopenia, upregulation of rank ligand, increases osteoclast-mediated destruction. Okay, then we have epidemiology. Most common inflammatory arthritis prevalent in 1% of population. Female is to male, 3 is to 1. Age of onset, 20 to 40 years. Signs and symptoms. A variable course of exacerbations and remissions. Morning stiffness greater than 1 hour, improve with the use, worsens with rest. Polyarthritis, symmetric joint involvement, tender, swollen, small joints affected, most commonly in hands and feet. MCP, PIP, MTP. Constitutional symptoms, profound fatigue, depression, myalgia, and weight loss. Extraarticular features. Okay, limitation of function and decrease in global function status, complications of chronic synovitis, signs of mechanical joint damage, loss of motion, instability, deformity, crepitus, joint deformity, swan neck deformity, boutonniere deformity, ulnar deviation and subluxation of MCP, and radial deviation of the wrist joint, hammer toe, mallet toe, and claw toe. Then flexion contractures, atlantoaxial and subaxial subluxation, C spine stability, neurological impingement, long track signs, difficult, dangerous intubation, risk of worsening subluxation and damage to spinal cord. Okay, limited shoulder mobility, spontaneous tears of the rotator cuff leading to chronic spasm, tenosynovitis may cause rupture of tendons, carpal tunnel syndrome, ruptured Baker cyst, outpouching of synovium behind the knee. Presentation similar to acute vein thrombosis, acute deep vein thrombosis. Poor prognostic factor include young age of onset, high rheumatoid factor titer, elevated ESR activity, of greater than 20 joints and presence of extra-articular features. Okay, let's see the sidebars. The picture here showing the botonier deformity.
What are the extra-articular features?
I think they have mentioned here. No, not yet. We'll see they'll mention here in the table. So before that, I want to go with the sidebars. Swan neck deformity, claw toe, and then this one is hammer toe and mallet toe. These are the joint deformities. Okay, syndromes in rheumatoid arthritis, Sjogren's syndrome, common keratoconjunctivitis sicca, and xerostomia. Dry eyes and mouth. Kaplan syndrome, very rare, combination of rheumatoid arthritis plus pneumoconiosis that manifest as multiple intrapulmonary nodules. Falty syndrome, rare, arthritis, splenomegaly, and neutropenia. Okay, so there now we have extra articular features of rheumatoid arthritis classified by underlying pathophysiology. Skin, periungual infarction, and cutaneous ulcers, palpable purpura. Okay, lymphocytic infiltration, rheumatoid nodules may have vasculitic
Joint syndrome also we get to see, this rheumatoid arthritis, because it's written only keratoconjunctivitis, sicca, and xerostomia. So this is the triad, right? So where it is the rheumatoid arthritis thing, because in another two, it's mentioned that rheumatoid arthritis will be there.
Yeah, like a joint pain along with these conditions. So it's basically they named it as Sjogren's syndrome. Okay, so ocular episcleritis, scleritis, lymphocytic infiltration, keratoconjunctivitis sicca, xerostomia, Hashimoto's thyroiditis. In cardiac, myocarditis, valvular disease, conduction defects. Pulmonary fibrosis, pleural effusion, pleuritis, and pulmonary nodules. Neurological, peripheral neuropathy, sensory stocking, glove, mononeuritis multiplex. Hematological, splenomegaly, neutropenia, Falty syndrome, renal amyloidosis caused by the accumulation of abnormal protein. Classification of global functional status in RA class 1, able to perform usual activities of daily living, self-care, vocational, avocational. Class 2, able to perform self-care, vocational activities, restriction of avocational activities. Class 3, able to perform self-care, restriction of vocational and avocational activities. Class 4, limited ability to perform self-care, vocational and avocational activities. Okay, investigations, blood work, rheumatoid factor 80% sensitivity but non-specific, may not be present at onset of symptoms. Levels do not correlate with disease activity, can be associated with more erosions, more extra-articular manifestation, and worse function. Anti-CCP 80% sensitivity but more specific 94 to 98% may precede onset of symptom. Increased disease activity is associated with decreased hemoglobin, anemia of the chronic disease, and increased platelets, ESR, and CRP. Imaging, bilateral hand and wrist, ankles, feet, X-ray. First change is periarticular osteopenia followed by erosion. C spine X-ray may be normal at onset, required for preoperative assessment in long-standing disease. Ultrasound with power Doppler, often changes of synovitis erosion noted in advance of those seen on plain X-ray. MRI may be used to image hands to detect early synovitis erosion. MRI T1
Okay, just a second.
inflamed.
Someone just asked that, okay, what are vocational and avocational activities? So vocational activities are related to the job, like the career-oriented activities, and avocational activities, related to sports or daily function activities. We can say that avocational and vocational activities.
Okay. So yeah, MRI may be used to image hands to detect early synovitis and erosions. MRI T1 inflamed synovium is hypointense and hyperintense on T2. Bone marrow edema can be seen as well as areas of increased uptake of gadolinium contrast. Okay, let's see the sidebars now. This one done. Symptoms. Okay. Poor prognostic feature of rheumatoid arthritis include young age of onset, high rheumatoid factor elevated ESR, activity of greater than 20 joints, and presence of extra-articular features. Side effects of steroids: weight gain, osteoporosis, AVN, cataract, glaucoma, PUD, susceptibility to infection, easy bruising, acne, hypertension, hyperlipidemia, hypokalemia, hyperglycemia, mood swings. DMARDs, prednisone, and biologics, but not analgesics or NSAID, altered the course of rheumatoid arthritis. Okay, so the treatment: goals of therapy: remission or lowest possible disease activity. Key is early diagnosis and early intervention with DMARDs. Window of opportunity: early treatment within first 3 months of disease may allow better control and remission. Assess poor prognostic factors at baseline: RF positive, functional limitations, and extra articular features. Behavioral exercise program: active, gentle, range of motion, isometric exercise during flares, aquatic aerobic strengthening exercise between the flares. Job modification, assistive devices as necessary, interventions to reduce cardiovascular disease, smoking cessation, lipid control. Pharmacological: alter disease progression. DMARDs and biologics, not analgesics or NSAIDs, can alter the course of rheumatoid arthritis. Treatment with DMARDs should be started as soon as RA diagnosis is made and should be aimed at reaching sustained remission. Okay, methotrexate is the gold standard and is the first line unless contraindicated. Prior to methotrexate therapy, CBC profile, liver enzymes, creatinine clearance, hepatitis B and C serology, and chest X-ray should be done. Monitor if inadequate response, 3 to 6 months, combine or switch. Consider combination therapy for methotrexate if patient have poor prognostic features or high disease activity. Therapy includes hydroxychloroquine, SSZ. Can somebody check the full form for SSZ? Leflunomide, biologics. If contraindicated to methotrexate, hydroxychloroquine, sorry, sulfasalazine. Okay, so if contraindicated to methotrexate, hydroxychloroquine and sulfasalazine or leflunomide should be considered, with the former being considered as a weaker agent and the latter as more potent. Biologics: DMARD should be used if inadequate response to DMARD should be combined with DMARD therapy. Initiating with combination therapy is associated with faster response rate and longer duration of effect. First line anti-TNF option: infliximab, etanercept, adalimumab, golimumab, and citrolizumab. Okay. Non-anti-TNF agents include anakinra, almost never used for RA, abatacept, rituximab, and tocilizumab. Reassess every 3 to 6 months and monitor disease activity predominantly via assessing swollen joint count. Tofacitinib, JAK inhibitor, is technically a synthetic DMARD used if other DMARDs fail. Pharmacological: supportive to reduce inflammation and pain. Okay, then NSAIDs, individualized according to efficacy, tolerability, and comorbidities. Contraindication and cautioned in some patients: PUD, ischemic cardiac disease, pregnancy, CKD, anticoagulant use. Add acetaminophen for synergistic pain control, corticosteroids, local injections to control symptoms in a specific joint, systemic oral prednisolone or IM. Low dose useful for short term to improve symptoms of NSAIDs are ineffective and to bridge gap until DMARDs take effect. Do baseline DEXA bone density scan and consider bone supportive pharmacological therapy. Example: bisphosphonates if using corticosteroids 7.5 mg per day greater than 3 months, particularly in those with other risk factors. Caution and contraindication: active infection, TB, osteoporosis, hypertension, gastric ulcer, and diabetes. Surgical: indicated for structural joint damage. Surgical options include synovectomy, joint replacement, joint fusion, reconstruction, tendon repair. Follow-up management and clinical outcome: clinical reassessment every month initially, then 3 to 6 months if still ongoing activity, then 6 to 12 months after inflammation has been suppressed. Examine joints for active inflammation. If active, consider adjusting medication, physical therapy, occupational therapy. RA patients should be screened and managed for cardiovascular disease given increased risk. If assessment reveals joint damage, consider analgesia, Referral to PT/OT, surgical options. Outcome depends on disease activity, joint damage, physical function status, psychological health, and comorbidities. Functional capacity is a useful tool for determining the therapeutic effectiveness. Many tools for evaluation have been validated. Patients with rheumatoid arthritis have an increased prevalence for other serious illnesses, infection, pulmonary, skin, uh, joint osteoporosis, mental disorder, renal impairment, lymphoproliferative disorders, cardiovascular disease correlates with disease activity and duration. Risk of premature mortality, decreased life expectancy, most mortality not directly caused by rheumatoid arthritis. Okay, so we have now SLE. Okay, definition: chronic autoimmune disease of unknown etiology resulting in multi-system inflammation, characterized by production of autoantibodies and diverse clinical manifestation. So the sidebar showing the diagnostic criteria for SLE: MD soap brain, malar rash, discoid rash, serositis, oral ulcers, ANA, photosensitivity, blood, renal arthritis, immune, and neurologic. Okay, then classification criteria for SLE. Entry criterion: ANA at a titer of greater than 1:80. Additive criteria: do not count criterion if there is more likely explanation than SLE. Occurrence of criteria on at least one occasion is sufficient. Within each domain, only the highest weighted criteria is counted towards the total score. Constitutional: fever 2 score, leukopenia 3 score, thrombocytopenia 4 score, autoimmune hemolysis 4 score. Neuropsychiatric: delirium 2 scores, psychosis 3 scores, seizure 5 scores. Mucocutaneous non-scarring alopecia 2 scores, oral ulcers 2 scores, subacute cutaneous or discoid lupus 4 scores, acute cutaneous lupus 6 scores. Okay, serosal, pleural, and pericardial effusion, it shows 5 scores. Acute pericarditis, 6 score. Musculoskeletal involvement, joint involvement, 6 score. Renal proteinuria greater than 0.5 gram per 24 hours, 4 scores. Renal biopsy class 2 or 5, lupus nephritis, 8. Renal biopsy class 3 or 4, lupus nephritis, 10. Okay, so this sidebar: a systemic review of guidelines for managing rheumatoid arthritis. 5 general principles for management. Start DMARDs as soon as possible following the diagnosis. The best initial treatment is methotrexate. Monitor disease activity regularly. Biologics should be initiated in patients with persistent active disease despite methotrexate treatment. Goals of treatment should be aimed at low disease activity or remission. Okay, so this is the multifactorial etiology of SLE. Environment, stress, virus, sun, hormonal, drugs, genetic, HLA, T cells. They all cause formation of autoantibodies, cytotoxic antibody, immune complexes. Cytotoxic antibody causes cell damage and death. Immune complexes causes inflammation. Okay, then immunological domains and criteria: antiphospholipid antibodies, anticardiolipin antibodies, or anti-B2-PG1 antibodies, or lupus anticoagulants. Score 2. Complement protein, low C3 or low C4, 3, low C3 and low C4, 4. Scoring is 4. Okay, SLE specific antibodies, anti-dsDNA or anti-SM antibodies. Score is 6. Etiology and pathophysiology: production of cytotoxic autoantibodies and immune complex formation, multifactorial etiology. Genetics: common association with HLA B8 and DR3, 10% have positive family history. Strong association with defects in apoptotic clearance. Fragments of nuclear particles captured by antigen presenting cell develop ANAs. Cytokine involved in inflammatory process and tissue injury: B lymphocyte stimulator, interleukin 6, interleukin 17, interleukin 18, and TNF alpha. Environment: UV radiation, cigarette smoking, infection, vitamin D deficiency, and silica dust. Estrogen: increase incidence after puberty, decrease incidence after menopause. Men with SLE have higher concentration of estrogenic metabolite, increased risk of SLE associated with use of combined oral contraceptive pills and hormone replacement therapy. Infection, viral, non-specific stimulant of immune response. Drug-induced antihypertensives, hydralazine, anticonvulsants, phenytoin, antiarrhythmics, prokinamide, isoniazid, and biologics. Antihistone antibodies are commonly seen in drug-induced SLE. Symptoms resolve with discontinuation of offending drug. Drug-induced SLE often presents atypically with systemic features and serositis, usually associated with antihistone antibody. Epidemiology prevalence 0.05% overall, female is to male 10 is to 1. Age of onset in reproductive year 15 to 45, more common and severe in Hispanic and Asian individual for African descent. Bimodal mortality pattern early within 2 year, active SLE, active nephritis, infection secondary to steroid use. Late inactive SLE, inactive nephritis, atherosclerosis likely due to chronic inflammation. Sign and symptoms characterized by periods of flares and remission. Okay, sign and symptoms of SLE: systemic fatigue, malaise, weight loss, fever, lymphadenopathy, hematological anemia of the chronic disease, hemolytic anemia, leukopenia, neutropenia, thrombocytopenia, pancytopenia, thrombosis, splenomegaly, hematuria. Okay, renal features: hematuria, proteinuria, glomerulonephritis, hypertension, peripheral edema, and renal failure. Dermatological photosensitivity, malar rash, discoid rash, oral ulcers, alopecia, hair loss, purpura, panniculitis, inflammation of subcutaneous fat and muscle tissue, and urticaria. Musculoskeletal polyarthralgias, polyarthritis, myalgia, AVN, reducible deformities of hands, Jacquard's arthritis, ophthalmic keratoconjunctivitis, Zika, episcleritis, scleritis, cytoid bodies, cotton wool exudates on fundoscopy, infarction of nerve cell layer of retina, cardiac pericarditis, CAD, non-bacterial endocarditis, Libman Sachs, myocarditis. SLE is independent risk factor for atherosclerosis and CAD. Vascular Raynaud's phenomena, livedo reticularis, motile discoloration of skin due to narrowing of the blood vessels, characteristic lacy or net-like appearance. Vasculitis, respiratory pleuritis, ILD, pulmonary hypertension, PE, alveolar hemorrhage. Gastrointestinal pancreatitis, SLE, enteropathy, hepatitis, hepatomegaly, dysphagia, esophagitis, intestinal pseudo-obstruction, peritonitis, mesenteric vasculitis. Neurologic and psychiatric, headaches, depression, psychosis, seizures, cerebritis, transverse myelitis, peripheral neuropathy, stroke. Okay, life organ threatening, cardiac, coronary vasculitis, malignant hypertension, tamponade, hematological, hemolytic anemia, neutropenia, thrombocytopenia, TTP, thrombosis, neurologic seizures, cerebrovascular accidents, stroke, respiratory, pulmonary hypertension, pulmonary hemorrhage, and emboli. Okay, then we have Raynaud's phenomena, vasospastic disorder characteristically causing discoloration of fingers and toes. White, blue, red. Classic triggers, cold and emotional stress. Investigations, ANA 98% sensitive but poor specificity, used as a screening test. ANA titers are not useful to follow the disease course. Anti-dsDNA and anti-SM are specific. Anti-dsDNA titer and serum complement C3, C4 are useful to monitor treatment response in patients who are clinically and serologically concordant. Anti-dsDNA increases, C3 and C4 decreases with disease activity. Antiphospholipid antibody, anticardiolipin antibody, SLE anticoagulant, and anti-beta-2 glycoprotein 1 antibody may cause increased risk of clotting and increased APTT. Consider SLE in a patient who has involvement of 2 or more organ systems. Treatment goals of therapy: aims for remission, prevention of flares, hydroxychloroquine plus minus glucocorticoid. Treat early and avoid long-term steroid use if unavoidable. For osteoporosis management, if high dose of steroids are necessary for long-term control, taper when possible, and add immunosuppressive therapies, methotrexate, azathioprine, mycophenolate. Treatment is tailored to organ system involvement and severity of disease. Moderate refractory disease can be treated with belimumab. All medication used to treat SLE require periodic monitoring for potential toxicity. Then dermatological sunscreen, avoid UV light and estrogens, topical steroids, hydroxychloroquine, musculoskeletal, NSAIDs plus gastroprotective agents for arthritis. Hydroxychloroquine improves long-term controls and prevent flares. Bisphosphonates calcium, vitamin D to combat the osteoporosis. Okay, then we have other considerations. Smoking cessation, immunization, influenza live vaccines are generally not recommended. For women with antiphospholipid antibodies, avoid estrogen-containing contraceptives because of increased risk of thrombosis.
Yes.
Then,
No. Do you think this one is ultrasound? We do or no? Really?
okay, organ-threatening disease.
So what's this for MCC? This is musculoskeletal. Also, we don't do. No.
Okay, so I'm continuing. Organ-threatening disease, a high-dose oral prednisone or IV methylprednisolone in severe disease, steroid-sparing agent azathioprine, methotrexate, mycophenolate can use mofetil or sodium. IV cyclophosphamide for serious organ involvement, cerebritis or lupus nephritis for clinical features of lupus nephritis. Refractory disease can be treated with rituximab. Okay, the arthritis of SLE can be deforming, but it is non-erosive in contrast to rheumatoid arthritis called Jacquard's arthritis. Okay, I'll just go back to see if there's any leftover sidebar. Okay, so Raynaud's phenomena we have done, yeah. Consider SLE in a patient who has involvement of 2 or more organ systems. Okay, antiphospholipid antibody syndrome. Okay, so we have 1 minute. The meeting will stop. Then let Hina share the link again. Then we'll continue with antiphospholipid antibody syndrome. This is the last topic for today. And please. And also open the rheumatology in the next tab. So once we're done with this, we go to the MCQs. Okay, so antiphospholipid antibody syndrome definition, multi-system vasculopathy manifested by recurrent thromboembolic events, spontaneous abortion, and thrombocytopenia. Circulating antiphospholipid antibodies interfere with coagulation. Primary APS occur in the absence of other disease. Secondary APS occur in the setting of connective tissue disease, including SLE, malignancy. Drugs, hydralazine, prokinamide, phenytoin, interferon, quinidine, and infections, HIV, TB, hepatitis C, infectious mononucleosis, catastrophic APS development within 1 week of small vessel thrombotic occlusion in greater than 3 organ systems with positive APLA, high mortality. Okay, manifestation of the sidebar, manifestation of antiphospholipid antibody, thromboembolic events, spontaneous abortion, thrombocytopenia associated with livedo reticularis, migraine headaches. Arterial and venous thrombosis are usually mutually exclusive. Classification criteria for APS. Criteria clinical vascular thrombosis, 1 or more clinical episodes of arterial, venous, or small vessel thrombosis in any tissue or organ must be confirmed by imaging or histopathology. Pregnancy, morbidity, greater than 1 death of morphologically normal fetus confirmed by ultrasound or fetal exam at greater than 10-week gestation, or greater than 1 premature birth of morphologically normal neonate before 34-week gestation due to eclampsia, preeclampsia, or placental insufficiency, or greater than 3 consecutive spontaneous abortion, less than 10-week gestation, excluding maternal anatomic and hormonal abnormalities, and paternal and maternal chromosomal causes. Okay, lab must be positive on 2 occasions at least 12 weeks apart. Lupus anticoagulant present in plasma detected according to the guidelines of International Society on Thrombosis and Hemostasis. Anticardiolipin antibody IgG and IgM plasma or serum present in medium high titer greater than 40 GPL or MPL or greater than 99th percentile measured by ELISA. Anti-B2 glycoprotein 1 antibody, IgG or IgM plasma or serum present in high titer greater than 99th percentile measured by ELISA. Okay, sign and symptoms, see clinical criteria, table 16. Okay, hematologic thrombocytopenia, hemolytic anemia, and neutropenia. Dermatological livedo reticularis, Raynaud's phenomena, purpura, lag ulcers, and gangrene. Treatment thrombosis, lifelong anticoagulation with warfarin, target INR 2 to 3 for first venous event, less than 3 for recurrent event, target INR greater than 3 for arterial event, or target INR 2 to 3 plus aspirin. Okay. Recurrent fetal loss, heparin and low molecular weight heparin plus aspirin during pregnancy, catastrophic APS, high dose steroids, anticoagulation, cyclophosphamide, and plasmapheresis. Okay, all this topic is short. We can just quickly go through scleroderma and then move to the questions. Okay, so are you guys agree with this, or you want to stay with the schedule?
No, we will do it, and then we will, if anyone wants, then we can revise it again, then start the MCQs.
Okay, scleroderma, that is systemic sclerosis, a non-inflammatory autoimmune disorder characterized by widespread small vessel vasculopathy, production of autoantibodies, and fibroblast dysfunction causing the fibrosis. Okay, so scleroderma, we have two types. There's localized and generalized. The localized type, in which there is no involvement of internal organs, mostly children and young adults. Morphia, hard oval patches on the skin. Linear line of thickened skin. Okay, let me just Google the picture of morphia and explain. So once the question is come in the exam, we must know. Yeah. Can you just put the picture of morphia? It is a discolor patches on the skin. Because sometimes in exam, they just give you the picture and say, write the diagnosis. So yeah, this is the morphia. It is a form of scleroderma that involves isolated patches of hardened skin on face, hands, and feet, or anywhere else on the body with no internal organ involvement. Like this is total dermatological presentation. It's like reddish or purplish or sometimes whitish. I mean, hypopigmented. Okay. So let's go back to the flow chart. Linear line of thickened skin. Generalized, limited, systemic sclerosis, and diffuse systemic sclerosis. Limited, it involves skin sclerosis restricted to hands, face, and neck. Third to fourth decade, pulmonary hypertension common and crest. Then diffuse systemic sclerosis, widespread skin disease proximal to wrist, can involve trunk, tendons, early visceral involvement, renal and pulmonary fibrosis. Okay, the sidebar, crest syndrome, calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, telangiectasia. Scleroderma is the most common cause of secondary Raynaud's phenomena. Okay, etiology and pathophysiology. Idiopathic vasculopathy, not vasculitis, leading to atrophy and fibrosis of tissue, characterized by several hallmark pathogenic features. Small vessel vasculopathy resulting in tissue hypoxia, production of autoantibodies, and fibroblast dysfunction leading to increased deposition of extracellular matrix. Resemblance of malignant hypertension. Lung disease is the most common cause of morbidity and mortality. The American College of Rheumatology, European League Against Rheumatism, EULAR, criteria for classification of scleroderma. Skin thickening of fingers of both hands extending proximal to the MCP. Sufficient criteria. Score 9. Skin thickening of fingers. Puffy fingers. Sclerodactyly. Score 2. Fingertip lesion. Digital tip ulcers. Fingertip pitting scarrings. 4. Telangiectasia. 2. Abnormal nail fold capillaries. 3. Pulmonary arterial hypertension. Interstitial lung disease. Maximum score 2. Pulmonary arterial hypertension. 2. ILD. Raynaud's phenomena score 2, scleroderma related antibody, anticentromere, anti-topoisomerase 1, anti-RNA polymerase 3, 2. Okay, so Raynaud's phenomena differential diagnosis, cold hand, cold, C for cryoglobulins, cryofibrinogens, obstruction, occupational lupus erythematosus, other connective tissue disease, D, DM and drugs, hematological problem, polycythemia, leukemia, etc. Arterial problem, atherosclerosis, anorexia nervosa. Neurological problems, vascular tone, disease of unknown origin, idiopathic. Epidemiology, female is to male, 3:4 is to 1, peaking in fifth decade, associated with HLA, DR1 and environmental exposure, silica, epoxy, resins, toxic oil, aromatic hydrocarbon, polyvinyl chloride. Limited systemic sclerosis has a higher survival prognosis, greater than 70% at 10 years, than diffuse systemic sclerosis, 40 to 60% at 10 years. Okay, sign and symptoms, clinical manifestations of scleroderma. Dermatological features, painless, non-pitting edema, skin tightening, ulcerations, calcinosis, periangle erythema, hypo and hyperpigmentation, pruritus, telangiectasias, characteristic face-like facies with light lips, beak, nose, radial, perioral furrows, vascular Raynaud's phenomena, digital pits, gangrene, thrombosis, gastrointestinal, distal esophageal hypomotility, dysphagia, loss of lower esophageal sphincter function, GERD, ulceration, stricture, small bowel hypomobility, bacterial overgrowth, diarrhea, bloating, cramps, malabsorption, weight loss, large bowel hypomotility, wide mouth, diverticula are pathognomic radiographic finding on barium study. Renal, mild proteinuria, creatinine elevation, and hypertension. Scleroderma, renal crisis may lead to malignant arterial hypertension, oliguria, microangiopathic hemolytic anemia, pulmonary interstitial fibrosis, pulmonary hypertension, pleurisy, pleural effusion, cardiac left ventricular dysfunction, pericarditis, pericardial effusion, arrhythmias, musculoskeletal polyarthralgia, resorption of distal tufts, radiological finding. Proximal weakness secondary to disuse, atrophy, low-grade myopathy, tendon friction rub. Endocrine hypothyroidism. So in the sidebar, features of pathological Raynaud's syndrome, new onset, asymmetric, precipitated by stimuli other than cold or emission, associated with distal pulp pitting or tissue reabsorption, digital ischemia, capillary dilatation by capillaroscopy. Investigation, blood work, CBC, creatinine, ANA, anti-topoisomerase 1, anti-scleroderma 70 antibody, specific but not sensitive for diffuse systemic sclerosis, anti-centromere antibody, favors diagnosis of CREST, limited systemic sclerosis, anti-RNA polymerase 3 antibody associated with severe skin involvement, increased risk of renal crisis, PFT assess and monitor for ILD, echocardiogram, rule out pulmonary hypertension, imaging baseline chest x-ray to rule out ILD, treatment dermatologic, good skin hygiene, low dose prednisone greater than 20 mg may provoke renal crisis if susceptible, methotrexate, limited evidence, vascular Raynaud's, keep hands and body warm, smoking cessation, vasodilators, CCBs, local nitroglycerin cream, systemic PGE2 inhibitors, and phosphodiesterase 5 inhibitors. Can somebody look what is PGE2 inhibitors? Fluoxetine, this is antidepressant. PGE2 inhibitor, yeah. Yeah, prostate. I think dinoprostone, they are saying PGE2.
They use PGE2 for cervical ripening.
Okay. Okay, so gastrointestinal GERD, PPIs are the first line, then H2 receptor agonists, small bowel bacterial overgrowth, broad spectrum antibiotics, tetracycline, metronidazole, motility disturbances, prokinetics, renal disease, AC inhibitor for hypertensive crisis, nephrology, okay, there's a separate topic for scleroderma renal crisis. Pulmonary, early interstitial disease, mycophenolate mofetil, less toxicity, or cyclophosphamide, pulmonary hypertension, vasodilator, bosentan, and epoprostenol phosphodiesterase inhibitor. I think that's sildenafil or something. Yeah. Rapidly progressive disease at risk of organ failure, consider hematopoietic stem cell transplantation. Cardiac pericarditis, systemic steroids, musculoskeletal arthritis, and NSAIDs. Myositis, systemic steroids. Okay, so we ended scleroderma. Let's move to the questions.